Instrumental swallowing assessments are exactly that, using instruments to visualize and assess swallowing function. There are two main instruments that are commonly used. The first is the Video Swallow Study, otherwise known as an MBS, or Modified Barium Swallow, or VFSS, the Video Fluoroscopic Swallow Study. And second is FEES, or Flexible Endoscopic Evaluation of Swallowing. Let's take a look at each of them. The Video Swallow Study uses fluoroscopy, or an X-ray movie, to look at swallowing. Patients will drink liquids and eat foods that have been mixed with barium, so it shows up on the X-ray. Here's an example of a normal swallow using this tool. FEES, or Flexible Endoscopic Evaluation of Swallowing, uses an endoscope that is inserted through the floor of the nasal cavity and allows visualization of the pharynx. During the swallow, there is what is called a whiteout period, but milliseconds before and after the swallow can be seen. And if aspiration occurred during the whiteout swallow period, is generally visible in the trachea. Both these tools are sensitive and specific and considered gold standards of the assessment of swallowing. In this presentation, we're going to discuss the problem in skilled nursing facilities related to swallow studies, who's affected by it, and the cost associated with this problem. To outline a solution, we'll identify current leadership and policy related to this problem, then propose a framework for progress and how to implement this change. In March of 2019, the ASHA Leader featured an article about instrumental swallowing assessments in skilled nursing and long-term care. They stated that some facilities do not allow their SLPs to order instrumental swallowing assessments, and without access to these tools, providing evidence-based practices is extremely difficult for the SLP.
By the late Stephen Leader, and it was called Comparing Simultaneous Clinical Swallow Evaluations and FEES, Findings and Consequences. And here I've just highlighted a few of the key points that I wanted to talk about. The research goal was to conduct blinded ratings of simultaneously recorded bedside and FEES using the exact same swallows, thereby allowing for control of both temporal issues and testing environments. The results: no consistent agreement was found between the clinical bedside evaluation and the FEES raters regarding pharyngeal and laryngeal anatomy and physiology, bolus flow characteristics, and oral diet recommendations. And really, they talked about that the clinical bedside evaluation does not have good clinical utility for determining pharyngeal dysphagia. It does not say that the clinical swallow evaluation does not have clinical utility, but just not for determining pharyngeal dysphagia. So this is an example of a patient who is silently aspirating. So with a clinical bedside evaluation, this isn't something that you would be able to necessarily see. So I'm going to play this for you. And you could see that first swallow, a lot of residue, and that second swallow, aspiration on the anterior tracheal wall. And again, something that you would not see with a clinical bedside evaluation. This is another tool that we have in our toolbox, the FEES. And so I'm going to play this for you just so that you can see another example.
So take a look at your voice box, Erin. Do you see that there's a little bit of saliva in there? Okay. So what I want you, good, you beat me to it. So you gave a big hard swallow to get rid of some of that. That's awesome. Do you feel like anything's stuck in your throat, Erin, or is it feeling clear? Yes, the scope is there. But do you feel any saliva sitting in your throat, or does it feel clear? Feels clear. And it looks clear, too, right? We're not seeing anything fluid. All right, here we go. One piece of peach. There it is. Does it feel like it's all gone?
Now that you're familiar with instrumental swallowing assessments, both the video swallow and FEES, let's compare it to the clinical bedside swallow assessment, which is often the only assessment SLPs are able to do in skilled nursing facilities.
Alright, I'm just going to check your swallow with different consistencies and different types of food. Alright, say off for me. Thank you. Thank you. Alright, awesome. Say off for me. Alright, thanks.
How does the SLP determine if someone is silently aspirating? How much and how often are they aspirating? And what textures are problematic? Thin liquids or solid foods? The answer is they don't, because no one has X-ray vision. And this is why current research is recommending the clinical bedside assessment be considered as just a screening tool, not a full assessment for pharyngeal dysphagia. Without instrumental assessment, research indicates SLPs miss up to 40% of the patients who are aspirating and recommend incorrect diets 68% of the time following a clinical bedside assessment. In other areas of medicine, we used advanced technology for diagnosing health problems, coming a long way from the old feel and guess strategy. So why are SLPs in skilled nursing expected to compromise their practice and attempt to diagnose pharyngeal dysphagia using outdated practices?
Who is affected? There are about 15 million people in the United States with dysphagia and an additional million people who are diagnosed with dysphagia each year. The ongoing challenge of healthcare has been to provide increasingly higher levels of care while maintaining tight financial budgets. A second area of concern or cause would be increasing the use of instrumentation for dysphagia evaluation and treatment, and SNFs may possibly increase initial healthcare costs.
And then there were 5 conditions that all account for 78% of all 30-day SNF rehospitalizations that could have been avoidable with careful monitoring, adherence to patient fluid and nutrition intake, and following appropriate positioning of residents with swallowing problems to avoid aspiration that could lead to pneumonia. So it's CHF, URI, UTI, sepsis, and electrolyte imbalance. And then what is the cost really to the patient? Patients really don't like the thickened liquids. It's not palatable for them, so they don't drink as much. And maybe they have the potential for dehydration. And actually, dehydration has been linked with people being on thickened liquids and having electrolyte imbalance and UTIs, again, due to the decreased palatability and patients just refusing to abide by having the thickened liquids. We really talk about the actual cost of treating dysphagia patients, and statistics tell me that it can cost up to $2,000 to $7,000 annually to keep one institutionalized patient on thickened liquids for 1 year. The cost of managing a patient with a feeding tube, which for many has been the primary treatment option for dysphagia, is reported to average over $31,000 per year, with 70% of patients reporting serious medical complications even having the tube. And then, of course, aspiration pneumonia is the leading cause of death and most common complications arising from dysphagia for our long-term care residents.
So let's take a minute to compare the cost of taking action using instrumental swallowing assessments to the cost of inaction, continuing to limit or deny access to instrumental swallowing assessments. Nationwide, the cost of a video swallow is approximately $1,200, and often patients may rely on the skilled nursing facility for transportation. More recently, FEES, the endoscopic evaluation, is being used because the equipment is portable and it can be done at bedside, which means no transportation cost. The national average expense for FEES is $350.
There are so many benefits to ensure that dysphagia patients are evaluated with objective measures. And here are just a few of those benefits. Providing best practice dysphagia care, improved quality of life for our patients, less cost to facilities and insurance companies, adhering to current guidelines from ASHA, from Medicare, from the American Board of Swallowing and Swallowing Disorders, as well as from the Dysphagia Research Society. And relying on objective clinical data and not just clinician intuition. And then finally, empowering all dysphagia clinicians to really use the appropriate tools that we have in our toolkit when suspecting a patient that has especially a pharyngeal or esophageal dysphagia.
Now, let's compare this with the cost of taking no action.
What are the costs of taking no actions? Well, sadly, dysphagia patients would be on more restrictive diets than they really need to be, and maybe for prolonged periods of time if you can't get access to instrumentation in a timely manner. A reduced quality of life for patients if they are restricted in their diets, if they're not able to have thin liquids, or if they require tube feedings. And then really no action is not abiding by the current ASHA, Medicare, ABSSD, and DRS recommendations for use of swallow instrumentation. And really, we're not providing evidence-based care. And there will be increased healthcare costs to both the patient and the facility with regard to tube feeding requirements, thickened liquid requirements. So all of that needs to be taken into consideration.